The current recommendation for wild-type metastatic colorectal cancer patients with metastasis to the liver is really open. If you base the data out of European studies, you will say that you would be better off with treating the patients of the left side with epidermal growth factor inhibitors. If you base it on the American studies, the data is less convincing, but still shows that left-sided tumors might benefit from the frontline use of epidermal growth factor inhibitors, while the right-side tumors appear to have very little benefit of epidermal growth factor receptor inhibitors. What we have seen nowadays is that there are some other studies that are showing that intervening in the liver in the patients that would have a worse prognosis in a much more aggressive fashion may be beneficial as well. And using certain technologies such as liver-directed therapies in those patients would be of benefit and change the prognosis of those patients. The use of FOLFOX as a mainstream therapy, it's also been something that has become kind of like an American tradition already. But if you look at the European studies, they tend to favor FOLFIRI. And honestly, there might be a lot to say about that, and that it might be that FOLFOX doesn't necessarily mean that it should be our frontline therapy, that we could use some other therapies such as FOLFIRI. Obviously, the problem is here the side effects and the toxicity profile that the patients are facing. We're seeing an increased incidence of alopecia in the patients that are being treated with FOLFIRI, and that's part of the reason that a lot of our patients may end up choosing a therapy with FOLFOX. There's also a lot to be said of the maintenance studies that have been done and the rationale behind using one backbone of chemotherapy versus the other one. The biologics that we are using nowadays for colorectal cancer are really divided in between the epidermal growth factor receptor inhibitors and the vascular endothelial growth factor inhibitors. The main discussion here is if we should favor the epidermal growth factor inhibitors on the left side and the vascular endothelial growth factor inhibitors on the right side. I don't think that the question is completely settled. And overall, what we have seen is that even in the setting where there is a possibility of a 4-month improvement in survival of using on the left side the epidermal growth factor inhibitors, for many reasons, and again, including quality of life, and there are studies that have been done about quality of life just secondary to skin issues on the left side, that a lot of patients end up choosing not going that route, even if it cost a 4-month improvement in survival by the phase 3 studies. The tumor sidedness affects the progression-free survival and the overall survival, regardless of the therapy that is given. We've seen a lot of panels and a lot of discussions that says that those statements, such as FOLFOX patients will do better if they are treated from tumors on the left side than tumors on the right side. The data of prognosis is so strong that even in between best supportive care, right-sided tumors versus left-sided tumors will do worse. If you look at historical data from the 90s, when our only drug was 5-fluorouracil, the difference in overall survival in between right versus left in meta-analysis could be measured already in 6 months. So we've seen this coming over and over. It's just that the new data is now stronger to separate the two groups, and we're starting to understand a little bit more of why.